Hello and welcome back. So basically you are at a platform of Unacademy platform, and the platform is basically Unacademy platform. So platform of Unacademy. Okay. So this is a platform of Unacademy whose whole source tagline is let's crack NEET PG. Okay, so our tagline is let's crack NEET PG, and for cracking NEET PG what you need to do is you need to be part of our family member. So you should be part of our family member, and obviously it's too cold now. See, it's too cold at present. Obviously you might be also be sitting in your bed. So but you also need to study, and I also need to take classes because life can't stop. So basically today we will be doing some compile pathology. So before starting anything, what I want to say is I want to introduce myself. So my name is Dr. Anil Sharma. So basically I am an MD pathologist from AIMS. Okay, so basically I am an MD path from AIMS Delhi, and basically you can be part of our family. And to be part of our family, what you need to do is just first step is you need to install our app, that is Unacademy learning app. So this Unacademy learning app, so you can install this app, and after installation of this app, Unacademy learning app, what you can do is you can just after installing you can subscribe. So what you can subscribe, you can be a plus, you can get plus subscription or iconic subscription. Okay, so plus subscription, what you will get live classes like I am taking now. Similarly, lot of good faculties take live classes. There are other teachers, and really there are a gem of teachers at Unacademy. They will be taking you live classes. Then you can also go for live test and quiz. You can take batch courses, or we have structure scheduled for you people. So whatever you are doing, like if you are doing internship, we have such type of structure schedule. You are doing you are just your target is to give NEET, or your target is to just clear your exam in next 3 months, such. So we have structure schedule for you. Similarly in Iconic you get all these things, plus you get prep letter. Okay, so the videos of prep letter, and prep letter again have very experienced teachers. Okay, I have met most of the teachers of prep letter, as I got to work with them once 1 year back. So you can have a question bank of 2.0, and what I think this is the gem point. Okay, so if you basically, I myself, I never did in any coaching center. I didn't do any coaching after my MBBS, but rather I just joined a test series and they did past year questions. Okay, though yeah, that might be, you feel like okay you took, but getting pathology at AIMS is also not a small thing, I think. So basically rapid revision course also we have, that will be, you will get it from the prep letter app, and you will be getting handwritten notes. So this all you can get iconic subscription by iconic subscription. So that will help you to clear or crack the exam, and together we will crack it. Let's crack NEET PG. So now how can you get this subscription? Obviously some amount is involved in that, and you can just get a 12-month subscription in 55,000 rupees, which after applying this promo code you can get it in 10% discount. Okay, so you can get it into 49,500 rupees, which implies you are paying 4,125 rupees for Iconic subscription. That is, you are paying 4,125 rupees for all the test series, live classes, and basically the question bank and everything. You don't need second option. आपको second चीज की जरूरत ही नहीं है. So that obviously is I think a beneficial deal for you all. So you can just use this promo code, and obviously there is plus subscription, where you can just get plus subscription for 12 months in 27,500. After applying the promo code you can get it into 24,750 rupees, again a 10% discount. You can apply a code over here, ANLIV, Anil Live. So basically this will help you to get 10% discount. And obviously NEET PG plus subscription have also lot of things to offer. So now why you can subscribe this. The best thing is the faculty over here. So you have a good teacher, a conceptual teacher, who will give you who will clear your conceptual knowledge regarding surgery. you have Dr. G. Rajesh. Now he is basically a Missa of medicine. Okay, so basically your all concepts regarding medicines can be cleared by him. Then you have Dr. Zainab Bora. So Dr. Zainab Bora, she is one of the best you can get in radiology. And Dr. Preeti Sharma, she is again one of the best you can get in pathology. Her knowledge about pathology and the way she teaches you, I think you are never going to forget that. And basically plus okay, भूलना ये अलग बात है, plus but those things which she teaches you are 100% you are going to get that exactly in exam. That is more important कि आपको हम जो पढ़ा रहे हैं वो exactly उसी तरीके से एग्जाम में आता है कि नहीं आता, because there are lot of questions to be solved. And basically the thing is as soon as you read a question, will you get or will that concept comes to your mind or not? If that concept comes in your mind, you are going to solve any question. So that is important. Most of the questions in exam are like आता है तो आता है, नहीं आता है तो नहीं आता. I feel like that is the theme in many exam. Most of the exam क्या होता है, आपको आता है तो आता है, नहीं आता है तो नहीं आता है. So basically that thing, and for that what happened, you need to obviously Dr. Preeti Sharma, Dr. Zainab Bora and all the faculties of our Unacademy will help you to get that part of the nahi aata ko aata banana. Okay, so that is what aim of Unacademy here. So now today we just this will be a series of compiled pathology. So I'll just try to try to compile it with different past year questions and all. We will do a system, and then we will also involve basic pathology of that system, and we will also do topic from general pathology, MCQ from general pathology also. So one subject from general pathology and one from system, and we'll try to cover. And in next 10 hours from today itself, in next 10 hours we will try to complete pathology, important part of the pathology. Okay, we'll try to complete all this. Then again we will just do again next 5 hours for those part which we might have missed. Okay, so basically in 15 hours I'll try to complete pathology from today's session. So we will take a 15-hour session basically, and then this session will help you to basically cover your pathology once before your exam. So basically maybe in March you are having exam, so before your exam you can cover complete pathology. And before you give your exam, at least 2 to 3 times you will be covering. So that will help you to understand that will help to solve maximum questions of pathology. So this is basically regarding, this question is related to adaptation, chapter 1. Basically now we can say chapter 2, so because the new book have sale as a basic unit at chapter 1. So this is adaptation, regarding adaptation. And in adaptation, so this is a type of adaptation in heart muscle. So basically today for the first system I will be covering is heart. I have taken some questions from heart, so basically that will help you. So the cause of adaptation given in the picture is, so what is the cause of adaptation? So this is basically trying to ask you the mechanism of adaptation. Okay, so here the first thing, यहाँ पे कौन सा adaptation हो रहा है. So to answer this question, first thing you need to know is which type of adaptation is occurring here. So and then first thing which you need to know is what is adaptation. Okay, so basically first thing you know what are different types of adaptation. So in adaptation what you have hyperplasia. Okay, you have hyperplasia, you have hypertrophy, you have metaplasia and atrophy. So these are basically different types of adaptation which you can see because of different type of stimuli. Okay, so among this adaptation, so similarly just remember dysplasia is not a part of adaptation. Okay, dysplasia is not a part of adaptation. Okay, and remember dysplasia is also reversible. Dysplasia is also reversible process, metaplasia is also reversible process. Okay, anaplasia is irreversible process. So now coming to this figure, so here you can see obviously this is a structure of a ventricle, and here you have muscles all have hypertrophized. Okay, so there you can see hypertrophy. So basically adaptation over here is hypertrophy. So the mechanism of hypertrophy will be basically the cause of adaptation, or the mechanism of this hypertrophy will be, so whenever you say hypertrophy, what happen in hypertrophy? So this is a structure obviously, okay, so this structure need to go hypertrophy, okay. So how will this structure will undergo hypertrophy? So here, suppose here we have cytoskeleton. So this cytoskeleton need to be increased, okay, this cytoskeleton need to be increased. And for increasing of cytoskeleton, what you need to do? So for increasing cytoskeleton, what you need to do? You need to form proteins, okay, आपको proteins बनाना है. And if you need if इस प्रोसेस को क्या कहते हैं, इधर से इधर जाने को, इसको एट्रोपी कहते हैं, यानी कि साइटोस्केलेटन का ब्रेकडाउन. सो फॉर ब्रेकडाउन ऑफ साइटोस्केलेटन क्या होना चाहिए? देयर शुड बी ब्रेकडाउन ऑफ प्रोटीन, ओके. सो देयर शुड बी ब्रेकडाउन ऑफ प्रोटीन, ओके. सो यूबिक्विटिन प्रोटियोसोम पाथवे से जो प्रोटीन्स का ब्रेकडाउन होता है, दैट इज बेसिकली यू कैन सी इन एट्रोपी. एंड द फॉर्मेशन ऑफ प्रोटीन का फॉर्मेशन कैसे होगा? सो बेसिकली इट्स mRNA which will be directing or transcripting the proteins, okay. So here the best answer will be mRNA, okay. So the best option over here will be mRNA. So here the cause of adaptation given in this picture image is basically mRNA. So with this question, what you can see get is, with this question you are knowing the concept of hyperplasia, which is increase in number, hypertrophy which is increase in basically in size, okay. Metaplasia, where is one form of epithelium is converting into other form, and atrophy matlab there is decrease in the size or loss of the organelle is occurring, okay. So basically what happen in metaplasia, hypertrophy, it is basically the different pathways which will result into the adjustment or adaptation of the body. So in heart, what happen whenever you have mechanical stress or increased workload, or whenever there are like agonists like alpha adrenergic which combines with the receptors, okay, they're like alpha adrenergic hormone, angiotensin. So this hormone, they react with this, or there are these growth factors which reacts with the receptors, so growth factor receptors, okay. So there are mechanical sensors like integrins which will sense this mechanical stretch in the heart muscle. So what happen there? They will activate a signal transduction pathway, okay, signal transduction pathway, okay, glycoprotein C pathway, okay, or they can activate PIP3 pathway, okay, PIP3 pathway they can activate them. So this signal transmit then will activate transcription factor like GATA A4, NFAT, MEF2, okay. So this transcription factor, what they will do, one thing, so they will form they will just adult genes, they will activate the fetal genes, okay, they will activate the fetal genes, because fetal genes are more efficient in the in walking, okay. So what they do, there is induction of embryonic fetal gene, okay. So whenever there is induction of embryonic fetal gene like atrial natriuretic factor, so this atrial natriuretic factor and all, they are found in fetus more than in the adult, okay. So cardiac like alpha actin, and what they will do, this they have more significant, or they have more higher good action of increasing mechanical performance and hence decreasing the workload, okay. Similarly they will increase the synthesis of contractile proteins, and again there will be increase of the mechanical performance, and there will again increase of the production of the growth factors which will again go and act on this growth factor receptors, and this pathway will form a cyclic pathway, okay. This will form a cyclic pathway. So now this is the basic mechanism of hypertrophy, okay. This is basic mechanism of hypertrophy, which is, this figure is in your Robbins. You can go and see this figure in your Robbins. Now see in heart muscle or myocardium hypertrophy, what happened? So this is the normal myocardium. These are the cardiac muscles, okay, these are the cardiac muscles, okay, myocytes which we call it, and this is the nucleus, this is the cytoplasm of this muscle, okay. So these are the nucleus. So now see here, the nucleus has also increased in size, okay, nucleus has also seen in size, and the cardiac muscles, they have increased, okay, they swollen up. So this is basically hypertrophy of the cardiac muscle, hypertrophy of the cardiac muscle. So this is an adaptation which you see in cardiac muscle, okay. Now remember, here you can see the hypertrophic cardiac myocyte, they have more cytoplasm, large nuclei which you saw in the previous figure than the normal cells. Okay, so here you see the cytoplasm. This is the cytoplasm, as I said. Okay, this is the cytoplasm, this one is the cytoplasm, this one is the nucleus. So this one is the nucleus. The nucleus, see, compare this nucleus with this nucleus. Okay, so this nucleus with this nucleus is a bit large in the size, and the cytoplasm has also increased. So this is basically a good example of hypertrophy of the cardiac muscle. Okay, that the final so remember, whatever there are the mechanism, exact mechanism is not clear, but the final step with include increase in the as a mRNA, RNA and the proteins. Okay, so basically hypertrophy result from transcriptional regulation. So now this can be again a MCQ. So it is a transcriptional regulation. Okay, formation of protein or hypertrophy is because of transcriptional regulation. Okay, so now this another question, not cause of constrictive pericarditis. Okay, so not cause of constrictive pericarditis. So I came forward this to this question. So basically when I saw some of the books, they have written the answer as trauma also. Okay, they have given the answer as trauma also. So basically for me, what I feel, the correct answer over here will be sarcoidosis. Okay, the correct answer over here will be sarcoidosis. As in your Harrison's also, it is written that the trauma is also one of the cause of constrictive pericarditis. Okay, trauma is also one of the cause of constrictive pericarditis. So, some of the books I saw and the past year question, this is a past year question. Okay, this have been asked in your NEET PG, this have been asked in your NEET PG in previously. So basically not cause of constrictive pericarditis is constrictive. So basically in heart you should know about constrictive pericarditis. Okay, so you will be from pathology, or it can be a medicine question also, constrictive pericarditis, cardiac tamponade. So these are some of the topics where you get question regarding from medicine or from pathology, anywhere you can see. So what are the causes of constrictive pericarditis? So the most common one in our setting, okay, in our setting is tuberculosis. So most common one is, the most common in our setting is tuberculosis, where though in developed world it is not TB, in developed world it is not TB, in developed world it can be some viral etiology, but in our case it is TB. Okay, so TB being the most common cause. Okay, other it can be like Dressler syndrome, it can be Dressler syndrome, uremia like in renal failure. Okay, CKD, renal failure, uremia, drugs like hydralazine and procanamide. Okay, and different infections. Okay, so now other causes which can be, this is a very important cause, acute or relapsing virus or idiopathic pericarditis. Okay, so basically acute or relapsing or idiopathic. So another important cause is idiopathic. So you can be given as of one option as idiopathic also. Now here see, your Harrison says that trauma with organized blood clot or cardiac surgery can result into, so trauma due to cardiac surgery or cardiac surgery, any kind of cardiac surgery, okay, that can result into chronic pericarditis. Okay, then you have trauma with organized blood clot can also be. So your trauma is the right option as Harrison says. Then radiations, okay, mediastinal radiations, purulent infections, histoplasmosis, toxoplasmosis can also occur, toxoplasmosis can also cause. Okay, toxoplasmosis. Then neoplastic diseases, so neoplastic diseases especially breast cancer, lung cancer and lymphomas. Then you have other autoimmune disorders, okay, related autoimmune disorders like rheumatoid arthritis, systemic lupus erythematosus or chronic renal failure treated by chronic dialysis. Okay, so hemodialysis, because of hemodialysis also they can cause. So these are basically causes of chronic pericarditis, and hence the option over here sarcoidosis, I didn't find sarcoidosis anywhere. Okay, so but some of the books I have seen, some of the answer it was like trauma. Okay, so now chronic constrictive pericarditis. So this is what your Harrison says, that chronic constrictive pericarditis, it results from, so chronic constrictive pericarditis, now this basically what you can do, you go to general path. Okay, so there is acute inflammation and chronic inflammation. So this chronic constrictive pericarditis is a part of, or it is a sequel of chronic inflammation. Okay, it's a type of chronic inflammation which you read, which we have done in general path. So now how chronic inflammation will occur? So chronic inflammation can occur by healing of an acute, So basically acute pericarditis, like acute pericarditis, it will be most common acute pericarditis is fibrinous pericarditis and serofibrinous pericarditis. Okay, so results from healing of acute fibrinous pericarditis or serofibrinous carditis, or it can be reabsorption of chronic pericardial effusion which is followed by obliteration of the pericardial obliteration of pericardial region. Okay, so now there can be formation of granulation tissue. So this is basically important with formation of granulation tissue. Obviously chronic, one very important part is formation of granulation tissue. Okay, then finally after granulation tissue, chronic part में क्या होगा, gradually contracts and forms a scar. Okay, so basically आपके पास क्या हो गया, it is a healing acute से acute का sequel हो गया, acute serofibrinous pericarditis or fibrinous pericarditis, which will form granulation tissue and finally form scar. So this is basically nothing much, but this is simple your way how you have defined your acute inflammation and chronic inflammation. So chronic constrictive pericarditis is nothing but it's a chronic inflammation. Okay, it's chronic inflammation. So the basic physiological abnormality क्या होगा? So now basically if this is hurt, okay, if this is hurt, basically you say this is hurt. So what happen if this is hurt, then what is going on here, over here is basically fibrosis. Okay, so basically when fibrosis is going on, suppose you have fibrosis over here, so now what happen, obviously whenever there is fibrosis, then contraction and all cannot take place properly. So basically here what you can see is the problem will be in the ventricular filling. So there is inability of the ventricular to fill because of limitation imposed by the rigid thickened pericardium. Okay, so now since this ventricle have undergone thickened one and there is not proper ventricular filling, now basically the main problem in this कहाँ पे दिखेगा, so it's diastole. The problem is at diastole. Okay, problem is diastole. In ventricular systole there will be obviously contraction, ventricle बहुत ज़्यादा contract करेगा, but in diastole कोई force नहीं है जो इनको feel कर सकता है. ठीक है. Now constrictive pericarditis, remember the problem is not in the early diastole. Okay, cardiac tamponade में the problem starts from early diastole and in is complete diastole phase में ही ये problem रहेगा. But in filling problem, but in case of constrictive pericarditis, early diastole is normal, but obviously the late diastole there is problem in late diastole. Okay, so that you need to remember a high yield point from your medicine point of view. So now with that you should also know that difference between cardiac tamponade and constrictive pericarditis. Okay, so you should also know cardiac tamponade and constrictive pericarditis का difference पता होना चाहिए, and also effusion constrictive pericarditis, the type of constrictive pericarditis, effusion constrictive pericarditis. Okay, and now the closely related with this constrictive pericarditis is restrictive cardiomyopathy. We'll talk about cardiomyopathy. So it is restrictive cardiomyopathy. Okay, and restrictive cardiomyopathy. So you need, and also with RVMI. Okay, so what is the problem over here? So what are the points you see obviously in the difference? So you see pulsus paradoxus, you see jugular vein. In jugular vein what you see prominent Y descent, prominent X descent and cosmal sign. Okay, cosmal signs. Okay, JBP देखते हो आप, pulsus paradoxus देखते हो, JBP देखते हो. Then you see about third heart sound and pericardial knock. Okay, then obviously these are the clinical things you see. Okay, clinical things you see when you differentiate between cardiac tamponade and constrictive pericarditis. So in investigation you see ECG and echo. Okay, ECG and echo and CT MRI. Okay, so this will differentiate between cardiac tamponade and constrictive pericarditis. So what you need to know is basically very important thing is this prominent Y descent. Okay, prominent Y descent and cosmal sign. So these are very important. Okay, so prominent Y descent and cosmal sign. So these are the two important things which you see, which you need to understand in case of cardiac tamponade and basically in case of this constrictive pericarditis. Okay, so see, in cardiac tamponade, in constrictive pericarditis, what you can see, you will be seeing prominent Y descent. Okay, and Kussmaul's, when if I say Kussmaul's, I can also say CU, cosmols, okay, cosmols, C, I can use C, it looks like C also. So C for C for constrictive pericarditis. So cosmol sign is positive in constrictive pericarditis, that is one way of remembering. And obviously descent, Y descent, so you have constrictive, in constrictive you have V, so V can be like Y, okay, so V can be Y, so Y will be descending, so the Y descent will be present in this, Y descent will be present in this. And prominent axe descent, so constrictive, so when you talk about constrictive, so you just constrictive, so axe in the spelling there comes like you, there is a axe also, so axe descent will be seen in constrictive pericarditis. But again axe descent will be also seen in cardiac tamponade, that you need to remember. So this is about prominent Y descent, prominent axe descent and Kussmaul sounds, okay. So basically these two different, prominent Y descent and Kussmaul sign, it differentiate this cardiac tamponade with constrictive pericarditis, okay. So you can see the Y descent also and Kussmaul signs both in constrictive pericarditis, but both are absent in cardiac tamponade. So this is very much important thing you need to know. Then another important thing you need to know is pericardial knock, okay, pericardial knock. Again this pericardial knock, so pericarditis, so obviously cardiac tamponade, so okay, pericarditis, so in pericarditis obviously there will be pericardial knock, so pericardial knock is present in pericarditis, okay, very much important. Now see, pulsus paradoxus will be very much present in tamponade, but this can be present in constrictive pericarditis, that is important point you need to remember. So this will differentiate between constrictive pericarditis and tamponade. But there is again one point which you need to remember is basically that is effusive constrictive pericarditis, okay. So in effusive constrictive pericarditis there is no Y descent, okay, there is no Y descent in effusive constrictive pericarditis, and there will be since there is effusion, so there will be no pericardial knock also. So by the concept itself only, effusion में पानी बीच में आ गया है, so obviously there will be no any kind of knock, pericardial knock नहीं होगा, and there will be no Y descent also, okay, there will be no Y descent, and there is prominent axe descent present, Kussmaul signs is present, okay. Now ECG, basically low ECG voltage can be present in both of this case, but electrical alternance, okay, electrical alternance. Now this is high yield point for tamponade. In tamponade you will see electrical alternance, in tamponade you will see electrical alternance, okay, tamponade you will be seeing electrical alternance. So remember, cardiac tamponade and effusion constrictive pericarditis, they are more or less similar thing, okay, they are more or less similar, except here what you have, Kussmaul sign is present in effusion constrictive pericarditis. Echocardiography, so what you see in echocardiography, so in echocardiography thickened pericardium, so it is not seen in cardiac tamponade. Pericardial calcification is not seen, but thickened pericardium will be seen in effusion constrictive pericarditis and constrictive pericarditis. Pericardial calcification can occur in constrictive pericarditis, okay. Pericardial effusion is seen in tamponade, and right ventricular size is usually small, but here see right ventricular size will be normal in case of constrictive pericarditis, okay. And remember CT and MRI, again thickened pericardium is not seen, and equalization of diastolic pressure is seen in both. So main difference is here, so main difference is here in clinical part, okay. You need to remember this in case of cardiac tamponade, constrictive pericarditis. So this table is from your Harrison, you can just go and see your Harrison also. So this table is given over there, and this table is a high yield where you can easily differentiate between constrictive pericarditis and cardiac tamponade with different variables of pulsus paradoxus, of jugular venous pressure, okay, JVP, where you will be seeing Y descent, X descent and Kussmaul signs, okay. Then you have third ultrasound and then pericardial knock. So they are clinical things which you need to see. Then you see ECG, you see echo, and obviously CT, MRI. So this again, this is saying you about the causes of acute and chronic pericarditis. So see, there are a lot of causes. We have already talked about each and every causes in our previous that thing, okay. So postcardiac scleroderma, cystic, so there is no sarcoidosis, so the answer to that question will be sarcoidosis, okay. Now another question, characteristic histological feature of rheumatic heart disease, okay. So when I say about rheumatic heart disease, so rheumatic heart failure or rheumatic heart disease, so characteristic histopathological feature will be basically Ascoff's nodule, okay. So I am talking about Ascoff's nodule in rheumatic heart disease or rheumatic fever. So basically Ascoff's nodules are very, they are the characteristic feature. So it's not that आपको macula मैककलम पैचेस भी दिखेंगे, ब्रेड एंड बटर पेरिकार्डाइटिस भी दिखेगा, बट एस्कॉप्स नोडुल्स दे आर कैरेक्टरिस्टिक्स, ओके, दे आर, एंड सैगी वेजिटेशन भी दिखेगा, बट you can see in acute rheumatic carditis Ascoff's nodules are characteristics. Okay, so the first thing what you need to know is pericarditis. So what type of carditis? So it is a pancarditis. So basically pancarditis involving all three layers, okay, all three layers, pericardium, myocardium and endocardium, okay, all three layers is involving, so it is known as pancarditis. Okay, so pericarditis involvement causes, so whenever there is pericarditis it will cause, so we have talked about in acute case it will be fibrinous and serofibrinous pericarditis, which is known as, also known as bread and butter pericarditis. Okay, so this is known as bread and butter. So serofibrinous exudate आएगा बीच में, तो कैसा आएगा, क्रीम जैसा आ गया ना, ब्रेड, दो ब्रेड के बीच में बटर डाल दिया, so that is bread and butter. Okay, that is bread and butter pericarditis, but it is not characteristic feature of rheumatic carditis. Okay, now it is involvement of pericarditis. So in pericarditis you see bread and butter pericarditis. In myocardium what you see, myocardium there is involvement, then you see Ascoff's bodies, you see Ascoff's bodies whenever there is involvement in myocardium. Okay, and endocardium is basically, endocardium it leads to the formation of small whitey projection or verrucae along the line of closure. Okay, this is a high yield point, कहाँ होता है, along the line of closure of valvular leaflet, mostly on the mitral valve. So these are the three things. In pericarditis you can see bread and butter pericarditis, in myocarditis you will see myocardium involvement, you will see Ascoff's bodies, and in endocardium you will see verrucae. Okay, there will be verrucae, formation of small warty verrucae which are basically along the line of closure of valvular leaflet. Okay, so that is important in case of acute carditis. Now you need to know about from the pathology, you need to know complete information about Ascoff's body. So these Ascoff bodies they are found in acute rheumatic carditis. Okay, that is important. So Ascoff bodies also known as Ascoff nodules. So how, what are they? They are basically, like as I said, what is carditis? It is a inflammation. Okay, so Ascoff's body is nothing but it is आपका जब acute inflammation chronic inflammation में बदलता है, तो then obviously this will be forming the giant cell type of reaction दिखाएगा. So उसी को Ascoff's body कहते हैं, ठीक है, Ascoff body. So this is nothing but एक chronic inflammation का एक result है. Okay, characteristic inflammatory lesion of acute rheumatic fever found any of the three layers. Okay, it's not only myocardium, it can be found in any of the three layers. That is again a high yield point. Okay, myocardium में most common होता है, लेकिन can be found in any of the three layers. Okay, so now what they will be there, they will consist of foci of collagens surrounded by cells like lymphocytes, it is the inflammatory cells, plasma cells, Ascoff's giant cells, Ascoff's cells, and histocytes and fibroblast. Okay, so this is important. What are the component of Ascoff's bodies? Okay, so there will be giant cells, there will be lymphocytes, there will be plasma cells, then there will be Ascoff cells, else there will be histocytes and all. Okay, so जो ग्रेनुलोमा में जो जैसे जैसे दिख रहा है लगभग वैसा ही है, ठीक है. Now what happen is you can, and now remember this is a high yield point. I said lymphocytes, I said plasma cells, I said Ascoff's giant cells, I said Ascoff cells, histocytes and fibroblasts, but I didn't say about neutrophils. So see, neutrophils are characteristically absent. Okay, so which of the following is not found in Ascoff's body? So which of the following is not found in Ascoff's bodies? Neutrophil. Neutrophils are not found in Ascoff's bodies. Lymphocytes मिलेगा, Ascoff's giant cells मिलेगा, plasma cells मिलेगा, histocytes मिलेगा, but not neutrophils. Okay, but not neutrophils. That is important point you need to know. You even find collagens but not neutrophils. Okay, that is important thing you need to know in Ascoff's bodies. Okay, so this figure basically this again from your Robinson Lee. So here this figure A is showing small verrucae along the line of closure. Okay, small verrucae along the line of closure, and these are the Ascoff's bodies. These are the Ascoff's bodies. So basically Ascoff's bodies, there will be combination of lymphocytes. Okay, there will be combination of lymphocytes, histocytes, lymphocytes, plasma cells. Okay, histocytes, lymphocyte, plasma cells, caterpillar cells, Ascoff cells. These are the Ascoff cells. So there are Ascoff cells. These all are the combination. Okay, Ascoff cells are the, so these are the Ascoff cells. They are the pathognomic for acute rheumatic fever. Okay, they are pathognomic for acute rheumatic fever. Then remember in chronic rheumatic heart disease. So this is mostly seen in acute rheumatic heart fever. Okay, in chronic heart disease, what you see fish mouth valvular stenosis and in McCallum plaque, okay, thickening of the left atrium. So left atrium will start thickening, so that is known as McCallum plaque. And also you can see fibrous commissural fusion, that is fish mouth valvular stenosis. So this figure again is clarifying you what these are the all caterpillar cells, okay. ये बेसिकली एनिस्कोप सेल्स और कैटरपिलर सेल्स कहते हैं इसको, एनिस्कोप सेल्स, ओके. सो ऑन एनिस्कोप सेल्स क्रॉस सेक्शन में ऐसा दिखेगा, एक्चुअली ऐसा होता है, ठीक है, लॉन्गिट्यूडनल में ऐसा होता है. So these are the aniscope cells, aniscope cells. So this is aniscope cells. This all are aniscope cells, and remember these are mononuclear cells but no neutrophils. Okay, there are no neutrophils in these cells. So now some of the basic point is most commonly involved valve in rheumatic carditis is mitral valve. Okay, most common lesion in acute rheumatic carditis is mitral regurgitation, and in chronic rheumatic carditis it is mitral stenosis. Okay, mitral stenosis. And obviously fish mouth valve बनता है chronic में, we know very well. Most common involved is mitral valve. mitral valve में भी most common acute है तो regurgitation होगा, acute है तो regurgitation होगा, और if it is chronic then stenosis होगा. chronic है जो stenosis होगा, okay, chronic है तो stenosis होगा, acute है तो regurgitation होगा, okay. And overall most common lesion is mitral regurgitation. Pulmonary valve is the least frequently involved, okay. So these are the important things which you need to know, that pulmonary valve is least involved in rheumatic carditis. Mitral valve are the most commonly involved. Mitral regurgitation is most common involved one, and mitral stenosis can be involved most commonly if in chronic rheumatic carditis, okay. So morphologically, remember this disease can be divided into 4 stages. Stage of mucoid swelling. So the first there will be mucoid swelling, and if you see slide also, in slide there will be lot of mucus membrane in the cytoplasm, okay, in the basically background. Then you have fibrinoid swelling. So the second there will be swelling, fibrinoid swelling. Then obviously there will be granulomatosis, and then finally sclerosis. It is obvious, okay, it is obvious as it goes on becoming chronic, there will be granulomatosis and fibrosis, okay. This is obvious general pathology knowledge. Another question. So deposition of which substance lead to tigroid appearance of heart? So tigroid appearance of heart. So which of the substance will lead to tigroid appearance of heart? So now tigroid appearance of heart is basically tigroid मतलब tiger skin, okay. So tiger skin में क्या होगा? There will be a whitish patch and then a blackish patch and whitish patch and blackish patch. So that type of patches you will see. So that is tigroid appearance, okay. So which of the substance will be forming that? It is fat, okay. So deposition of fat will result into development of tigroid appearance of the heart. So tigroid effect it is grossly apparent bands of yellowed myocardium which is containing fat alternate with the bands of darker red brown uninvolved heart, okay. So the part which is involved, that will be yellow color, and the part which is not involved, that will be darker color, red brown color, okay. So see here, basically this is showing yellowish color and this is uninvolved. So this is involved, this is uninvolved, involved, uninvolved. So this appears like tigroid, okay. So this is involved, non-involved, this is involved, this is involved, okay. Carcinoid tumor of heart most commonly involves. So where do you find carcinoid of tumors, okay. So now this is basically very easy question, endocardium, because carcinoid tumor is a cardiac manifestation of the systemic syndrome caused by carcinoid tumor. It generally involves the endocardium and valve of right side of the heart, okay. Now these two important things you need to know. Carcinoid tumor basically involving carcinoid tumor involving endocardium, and second thing valve of right side of the heart, okay. So right side का valve of the right side of the heart, so pulmonary valve सबको involve करेगा. Cardiac lesion consist of form plaque like endocardial fibrosis, thickening on the inside surface of the cardiac chamber, and tricuspid and pulmonary valve, okay. So another question is most common primary cardiac tumor is. So most common primary cardiac tumor. So here most common primary cardiac tumor. So यहाँ पे कुछ दिया नहीं है, basically it's there are nothing like age has not been given, okay, age has not been given, and so the most common primary cardiac, it is asking about primary. So most common tumor cardiac tumor is secondaries, okay. Most common cardiac tumor is secondary, and most common primary cardiac tumor is myxoma. So the most common primary cardiac tumor overall is cardiac myxoma, okay. Most common cardiac tumor is metastasis or secondaries, okay. Most common primary tumor in adult is cardiac myxoma. Most common primary tumor in infants and children is rhabdomyoma. Okay, so this you need to remember. Overall cardiac myxoma, overall common tumor is metastasis. Okay, so this is a high yield point, or basically a single liner which you can get in your exams. Okay, which of the following is not part of Carney syndrome? Okay, so in cardiac tumors you get Carney syndrome. So which of the following is not a part of Carney syndrome? So basically in cardiac myxomas you get Carney syndrome. So cardiac myxoma. So which of the following is not part of Carney syndrome? So cardiac myxoma, this is the most common you get in Carney syndrome. Okay, then obviously Carney syndrome, obviously it is cardiac myxoma. Then another place where it goes down is, it is basically seen in case of Leydig cell tumor, steroid tumor. Okay, so that is germ cell tumor. So how I mostly remember is basically Leydig cell tumor, and then it also can be seen in Pseudomonas melanotic schwannoma. So this is very rare. This is a rare type of schwannoma, Pseudomonas melanotic schwannoma. So it can be seen in this also. So basically which of the following is not part of Carney syndrome? So Spitz-Nevi is not a part of Carney syndrome. Okay, so here we know something about Carney syndrome is, Carney syndrome is an autosomal disorder disease. Okay, mainly the mutation involved is PRKR1. Okay, so PRK area that acts on a tumor suppressor gene on chromosome 17. Cardiac myxoma are present in 65% of the cases. Okay, and multiply and most serious component of the disorder. Okay, so it is main component of this Carney syndrome. So 25% of women with syndrome have breast. Now remember, they can also this cardiac myxomas, along with cardiac myxoma they can also have breast myxomas. Okay, so along in Carney syndrome they can also have breast myxoma. So this can be also a point for MCQ. So Carney syndrome, this also is associated with endocrine tumor involving adrenal gland, pituitary and testes. So they will involve different organs like adrenal gland, pituitary gland and testes. Okay, pituitary gland and testes. So in basically testes is where we need to understand that in both Sertoli cell tumor and steroid type tumor including Leydig cell tumor occur in these testes. An uncommon schwannoma variant, that is Pseudomonas melanotic, is seen in the disorder. So remember, Carney syndrome is also associated with skin pathology including myxomas and lentiginous and blue nevi. So they will be they are associated with myxomas, lentiginous and blue nevi, but not Spitz nevi. Okay, Spitz nevi नहीं है. So this you need to know. It nevi के साथ तो associated होता है. Carney syndrome is associated with lentiginous and blue nevi. So they are associated with lentiginous and blue nevi, but not with Spitz nevi. Okay, Carney syndrome is not associated with Spitz nevi. That is what you need to know from this question. Okay, which cardiac tumor has gamma Gandhi bodies? So gamma Gandhi bodies you might have heard a lot of time in spleen. So their gamma Gandhi bodies can also be found in case of cardiac tumor. So basically it is myxoma again. Okay, so gamma Gandhi bodies basically they are formed by calcific elastic fibers degenerated with hemosiderosis and are seen in cardiac myxoma. Okay, so gamma Gandhi bodies कैसे बनते हैं? They are found from the calcific elastic fiber degeneration. Formed by calcific elastic fiber degeneration with hemosiderosis. So there will be elastic fiber degeneration with hemosiderosis that can be seen in cardiac myxoma. Okay, gamma Gandhi bodies we know very well, it is seen in spleen associated with cardiac congestion and sickle cell anemia. But yes, gamma Gandhi bodies can also be seen in basically myxomas. Okay, foci of, now again remember in myxomas what you can cardiac myxomas, in cardiac myxoma you can also get extramedullary hematopoiesis. Okay, extramedullary hematopoiesis भी होता है. So foci of extramedullary hematopoiesis are present in 5 to 10% of cardiac myxomas. Okay, which of the following is not associated with tuberous sclerosis? So when we are talking about cardiac tumor, then tuberous sclerosis is again a very much important point you need to know. So which is of the following? So adenoma sebaceum, it is most commonly associated. Cutaneous angioma associated. Cardiac rhabdomyoma में tuberous sclerosis associated होता है. So it is the retinoblastoma. Okay, it is not associated in the retinoblastoma. Tuberous sclerosis is not associated in retinoblastoma. Remember, tuberous sclerosis ये neurocutaneous syndrome है, where in cutaneous what you can see, adenoma sebaceum, you can see angiomas, ash-leaf spots, Sjagren patches, fibromas and caffeolate spots. Okay, सो बेसिकली यू कैन सी एंजियोमास दिख सकता है, एडिनोमा सिबिसोमा दिख सकता है, एंजियोमा दिख सकता है, एस लीफ दिख सकता है, साग्रीन्स पैचेस दिख सकते हैं, ओके साग्रीन्स पैचेस दिख सकते हैं, एंड यू कैन फाइब्रोमास एंड कैफेओलट. सो आपको कहाँ पे क्वेश्चन पूछता है, ऑब्वियसली एस ग्रीन लैब तो पता है, साग्रीन पैच के क्वेश्चन पूछता है, फाइब्रोमास मस्टली भूल जाते हैं, सो फाइब्रोमास से क्वेश्चन पूछता है, ओके. सो बेसिकली देयर इज एडिनोमा, एंजियोमा, फाइब्रोमा, ओके, एस लीफ स्पॉट्स, साग्रीन पैचेस एंड कैफेओलेट स्पॉट्स. So and remember 90% of the patient they will have seizures and 60 to 70% will have mental retardation. So seizure and mental retardation is another presentation of tuberous sclerosis, okay. Tumor associated with syndrome include white matter hematomas and cardiac rhabdomyomas. So most commonly is cardiac rhabdomyomas, which you need to remember, okay. The white matter hematoma can also be associated with tuberous sclerosis, but in tuberous sclerosis you need to remember most important is cardiac rhabdomyoma, okay. You need to remember different things or different manifestation of basically of tuberous sclerosis. Remember the eye involved by retinal, eye में क्या होगा, there will be retinal hematoma, retinal giant cell astrocytoma, okay. Then there will be hypopigmented iris but not retinoblastoma, okay. So in retina what are the three things which you can see is, एक retinal hematoma दिख सकता है, retinal giant cell basically astrocytoma दिख सकता है, and hypopigmented iris spot दिख सकता है, ठीक है. hypopigmented iris spot दिख सकता है, retinal hemorrhage होगा, and retinal giant cell astrocytoma मिलेगा, okay. giant cell astrocytoma but not retinoblastoma. So these are the different places where you can see the places where the effect of, you can see the effect of basically you can see in different places in rhabdomyoma or TSC, so tuberous sclerosis. Like in brain 90% epilepsy will be shown, 80 to 90% you can see subependymal neoplasm, okay. You can see, so then you can see 10 to 15% SEGA, okay, subependymal glioma, you can see astrocytoma, okay. Then you can see 90% TND, 50% intellectual disability can be seen, 40% autism spectrum disorder can be seen. In others like 50% oral fibromas can be seen, or retinal astrocytic hematomas will also be seen. In skin you can see 75% angiofibromas, 20 to 80% ungual fibromas can be seen. Fibrous cephalic plaque is present, greater than 50% Sjogren patches, and greater than 90% focal hypopigmentation will be present, okay. Lymphangioliomyomatosis can be present in lungs, okay. lungs में lymphangioliomyomatosis present होता है. 5 to 10% symptomatic lymphangioliomyomatosis can lead to respiratory failure. Men and women in 10% you can see MMPH can be also seen. In the kidney it can be seen 70% angiomyolipoma, 35% simple multiple cyst, 5% you can see polycystic disease, and 2 to 3% of renal cell carcinoma, okay. So basically in kidney angiomyolipoma is more important, renal cell carcinoma is less important, polycystic disease and simple multiple cysts are important. In heart what you can see 90% cardiac rhabdomyoma that we will see again in infants. Adults 20% cardiac rhabdomyoma you can see, okay. So this is basically basic thing or basic diseases which are associated with TSC or basically tuberous sclerosis. Ultrastructural examination of cardiac neoplasm shows tumor cells with peripheral cellular junction that resembles intercalated disc and a cytoplasmic distension by glycogen based on the feature. So this is basically classical feature of rhabdomyoma. This is classical feature of spider cells, okay. So now the next question, which of the following statement regarding cardiac rhabdomyoma is true? They are associated with gene mutation on chromosome 17. So basically this we have talked about, they are not associated with gene mutation where there. It is tuberous sclerosis which is associated with this gene mutation. They are 100% myogenic immunoreactivity. No, they are not 100% myogenic. Spontaneous regression is possible. Now this is very high yield point and high point you need to remember about cardiac rhabdomyomas, that they can undergo spontaneous regression, okay. Prognosis is determined by embolic sequelae. So rhabdomyoma, what you need to remember, it's the most common benign primary tumor of heart in the children. It is associated with tuberous sclerosis. It undergoes spontaneous regression. Spider cells are present. Earliest prenatal manifestation, okay. So this thing you need to remember. So they can be solid or multiple. Most common primary benign tumor in infants and children. It is commonly associated with tuberous sclerosis. Multiple cardiac rhabdomyomas prenatally is the earliest manifestation of tuberous sclerosis. Site is left ventricular and ventricular septum. So this is again a very high yield point which is asked out. So what is the most common site? It is left ventricular, or they can also give you left ventricular septum. Okay, that can also be asked in your exam. And the most earliest manifestation, what you can see. So this is basically multiple cardiac rhabdomyomas is the earliest manifestation. Other sites you can have at tongue and soft palate. That is again a very high yield point. There are chances that in tongue and soft palate also you can have this rhabdomyomas. Okay. So we have already talked about that they are associated with tuberous sclerosis, where TS1 secrete for or code for hamartine and TS2 code for tuberine. Okay. They are form white, well circumscribed, non-encapsulated nodules. In tuberous sclerosis, multiple miliary nodules less than 1 mm are found, and they are known as rhabdomyomatosis. Okay. And if the tumors are large, then large tumors are mostly sporadic cases. Okay, they are mostly sporadic cases. Most common in left ventricular and ventricular septum. Multiple tumors in tuberous sclerosis, there will be multiple tumors. Okay, sporadic there will be single but large. Diagnosis you can do prenatally by fetal echocardiography. In the fetus, what you do, you can in fetus the major clinical pictures you will see that is non-immune hydrops and fetal dysarrhythmias. In infants you see congestive heart failure, infant respiratory distress and arrhythmias. Okay, so this is an example which is showing you rhabdomyoma. So example of a rhabdomyoma basically you can see here. Then homogeneous well circumscribed imaging में. So histopathology is what is more important. So you can see nodules of enlarged cardiac myocytes, clear vacuolated cytoplasm with a distinct cell membrane. Okay, there will be spider cells, that is a strand of eosinophilic material from the nucleus to cytoplasmic membrane. Okay, and there will be occasional eosinophilia can be seen. Pass positive diastase sensitive material reveals glycogen. Okay, so this is basically all what you can see. So here you can see basically these are vacuolated one. So here you can see vacuolated. So the vacuolation can be seen, but from nucleus to the cytoplasmic membrane something is going. Okay, so these are the spider like spidery. So this is called spidery. Okay, all these are vacuoles which are present in case of cardiac rhabdomyoma. Okay, so these are the vacuoles which are present in the cardiac rhabdomyoma. When a pass positivity will be showing, and this pass positivity will defines that it is because of these cells. Okay, this pass positivity is because of, so this is showing pass positivity. So pass positivity basically diastase. Okay, the diastase. Now treatment, and so it is again important, there will be spontaneous regression. Okay, spontaneous regression can be seen. Other tumors with spontaneously regress is neuroblastoma and thymoma. Okay, these are important. Spontaneous regression can be seen in this tumor, and other tumors which can be showing spontaneous regression is neuroblastoma and thymoma. Okay, and then obviously in patient is symptomatic, you go undergo surgical resection. Antiarrhythmic drugs you can see. You can give in antiarrhythmic drugs. Most frequent time period between myocardial infarction and subsequent myocardial rupture is. Okay, so infarction to rupture, remember it can take place anywhere between 3 weeks, but most common time period is 3 to 4 days. Okay, that is important, you need to remember. Okay, so anywhere between 3 weeks it can take place, but most common is 3 to 4 days. Which type of MI is most commonly associated with formation of aneurysm? Okay, so which of the following aneurysm MI can form aneurysm? So it is anterior. Okay, anterior. So aneurysm, anterior can form aneurysm. Okay, that you need to remember. Okay. So now this is basically what are the effect of myocardial infarction. So what happen in myocardial infarction? There will be contraction dysfunction, there will be arrhythmias. Okay, so basically arrhythmias and contractile dysfunctions, these are two things which you see mostly in case of infarction. Infarction हो गया, अब contract नहीं कर पाया and there will be arrhythmias. Okay, so which type of arrhythmias? Ventricular premature contraction are the most common arrhythmias. Okay, so this is again you need to remember VPMC. So ventricular premature contraction arrhythmias are the most common arrhythmias which we see after MI. Okay, most common cause of death is basically ventricular fibrillation, but the most common cause of death in case of myocardial infarction is ventricular fibrillations. Okay, ventricular fibrillation frequently associated with cardiogenic shock, then obviously this ventricular fibrillation, they are associated with cardiogenic shock. Then there will be heart block, so there will be ventricular arrhythmias. Okay, there will be a heart block which occurs in 5% of inferior AMI and 3% of anterior AMI. Okay, so heart blocks occurs mostly in inferior one, anterior one में भी कम 3% तक होता है. Okay, so cardiac rupture most commonly occurs between 3 to 7 days. Anything ranging between 3 to 7 days or 10 days, cardiac rupture will be occurring. Okay, so here there will be anterior wall rupture. So this anterior wall rupture basically produces cardiac tamponade associated with thrombosis of LAD and coronary artery. Then another, there is posteromedially papillary muscle rupture. Okay, so this is most common associated with inferior AMIs. Okay, so posteromedial is associated with AMI. Acute myocardial infarction is posteromedial. Okay, so posteromedial and basically anterior wall rupture will be seen in LAD, coronary artery and thrombosis. Present with an acute onset of mitral valve regurgitation and left heart failure. Interventricular septum rupture, IVS rupture, it is more common as with thrombosis in LAD and coronary artery, produce left to right shunt causing right heart failure. Okay, so that's you need to remember three things: anterior wall rupture, posteromedial papillary muscle rupture, and basically interventricular septal rupture. So these are important things which you need to know in case of rupture. Another complication is acute autoimmune pericarditis. Okay, it usually occurs 1 to 8 weeks. That is again important after STMI infarction. Okay, ST elevation myocardial infarction. Autoantibodies are directed against the damaged pericardial antigen. That is type 2 hypersensitivity reaction. There will be fever and precordial friction drop are present in case of Dressler syndrome. Okay. Now pathological complications of myocardial infarction. There is infarct extension, mural thrombosis, which occurs in 10% of acute myocardial infarction, most common associated with basically LAD, coronary artery thrombosis, and danger of peripheral embolization can be seen. Okay, due to anterior transmural infarction, there will be free wall rupture, mural thrombi or thromboembolism, ventricular aneurysm and infarct expansion. And due to posterior inferior transmural infarction, there will be conduction disturbance, that is arrhythmias, right ventricular infarction. Okay, ventricular aneurysms matlab they are clinically recognized within 4 to 8 weeks after ST elevated EMI. This begin to develop in first 48 hours. Then there will be precordial burst occurs during the systole. Blood enters the aneurysm causing anterior chest wall movement. So the next question is, the following is the hematoxylin HE stent section from heart of a patient after myocardial infarction. What can you say about the age of infarction? Okay, so age of infarction, what is happening over here? So you can see these are the nucleus. Okay, these are the nucleus. In most of the cell there is loss of the nucleus. Okay, there is loss of the nucleus. So what happened? This type of thing can be seen in case of within 6 hours of period. Okay, so what you need to know is there is necrosis. Those wherever there is nucleus is lost, there is cognitive necrosis. Okay, along with wavy fibers with widened space between the dead fibers, which contains edema fluid and scattered neutrophils. No dense neutrophilic infiltrate is seen. These are typical early changes of MI seen within 6 hours of infarction. Okay, so here you can see basically these are very less amount of neutrophils. Okay, you can see, and these spaces all are edema. These spaces are edema. Nucleus gayab hai. See, these are the contraction band. These are the contraction band which are forming, and this is basically the nucleus is lost from this cell. So this nucleus or there. So this is basically cognitive necrosis. Okay, architecture of the muscle fibers are still maintained, but nucleus have been lost. So that is cognitive necrosis. Okay, so here this table again is a very important thing you need to know. Okay, in the first 30 minutes grossly there will be no change, and there in light microscopy also there will be no change, and that is the only time where the injury is reversible. After 30 minutes of time, and when things you start changes or when you start seeing something, that is always irreversible injury. So basically from 30 minutes to 4 hours of time grossly there is no change. Okay, so basically remember, for grossly for 12 hours you don't see any kind of change, but from 30 to 4 minutes what you can see changes in the muscle. So muscles में क्या होगा, blood supply नहीं गया है, so those muscle they will start they will start forming waviness. Okay, they will start forming waviness of the fiber at the border. Okay, then in 4 to 12 hour what happen? Now these cells, they will start undergoing necrosis. Okay, so there will be beginning of the coagulative necrosis, edema and hemorrhage. The now after 12 hour, that is a half of day में तक होते हुए मसल्स मरने लग गए, नेक्रोसिस होने लग गया. नाउ आफ्टर half day, that is from 12 to 24 hour, there will be cross dark mottling can be seen. But then this side clinically microscopically you can see coagulative necrosis has increased, and there you can see marginal contraction band necrosis. Beginning of neutrophilic infiltration will start. Okay, acute inflammation शुरू हो गया अब. Basically necrosis results acute inflammation, we know very well. Apoptosis doesn't result in acute inflammation, but necrosis will result acute inflammation. So this necrosis will start forming or will attract neutrophil infiltration. Okay, so this happens till 1 day. So एक दिन पूरा दिन लग जाता है neutrophils को आने में. ठीक है, so the first day there will be necrosis, contraction band and neutrophils, and dark mottling शुरू हो जाता है. नाउ आफ्टर 1 to 2-3 days धीरे धीरे अब ये येलोइश कलर का होना लग जाएगा. सो मॉटलिंग विल बी इन येलो 10 infarct center. Okay, in 1 to 3 days, and obviously this side coagulative necrosis will continue, interstitial and neutrophilic infiltration शुरू हो जाता है. After 3 to 7 days there will be hyperemic border central yellow 10 softening. So beginning of disintegration with dying neutrophils, early phagocytosis by macrophages. So अब macrophages आ जाएगा. Okay, then on 7 to 10 days this will be maximum yellow 10 and soft depressed red 10 हो जाएगा. So 10 basically 10 मतलब yellow 10 and red 10. So 10 का बात किया तो there will be yellow 10 and red 10. So early formation of fibrovascular. Now after 7 to 10 days, after 1 week, granulation tissue starts forming. Okay, 7 दिन तक macrophages आ गए, अब granulation tissue start forming. From 10 to 14 days that will be red gray depressed infarct border. There will be well established granulation tissue will be forming from 10 to 14 days. 2 weeks, that is 14 to 8 weeks, you can see now gray white scar progressive from border towards infarct core. There will be collagen deposition, reduced cellularity. In greater than 2 months, scarring will be complete. Okay, so there will be dense collagen scar after 2 months. So that is again asked question. So this figure basically, so this is figure this is this first figure. You can see in the first figure you can see necrosis and all, and nucleus have gone over. Okay, so this basically there is reversible injury, there is no change, but this is basically injury is seen. Fibers, wavy fibers, the nucleus have been lost, and these are basically, you can see here you can see contraction band also, there you can see contraction band also. So this they say wavy fibers and contraction band. So this type of thing you can see up to where, and little bit of neutrophilic infiltration can also see, but अभी तक बहुत ज़्यादा neutrophil infiltration नहीं हुआ, यानी कि एक दिन तो पूरा हुआ नहीं है. So this can be seen in basically in first 6 hours. Okay, coagulative necrosis and वो maintain करके रखना. Then here see here all neutrophils आ गया, acute inflammation आने लग गया है. Okay, so this is basically seen in first days, that is 12 to 24 hour. Now in this place what you can see here, the neutrophils have increased lot. Okay, so neutrophils have increased in a huge amount, and this can occur in 1 to 3 days. Okay, then now these neutrophils are replaced by chronic inflammation, that is macrophages and all. Okay, acute inflammation of chronic inflammation में convert होने लग गया है. So this chronic inflammation or macrophages, they take place or they come around at 3 to 7 days. Okay, now after macrophages what happen, there will be granulation tissue formation होने लग जाएगा, blood vessel दिखने लग गया. Okay, so this granulation tissue fibrosis होने लग गया, and this place here of fibrotic scar has formed. Okay, this is fibrotic scar has formed. These are the muscle, these are the fibrotic scar. The bluish color is the fibrotic scar. So the fibrotic scar has formed here. So this is basically seen in 2 months of period of time. Okay, so now next question is, a 68-year-old man had severe chest pain. The patient died on the way to the hospital. In the hospital, at autopsy, tetrazolium chloride staining of heart was done. What will be the color of the viable myocardium? So tetrazolium chloride, basically it is used to see the gross of the heart. Okay, gross, so we use in the gross. So basically tetrazolium will for the viable it will stain red color, and for the basically non-viable it will not be staining. Okay, so basically the answer here will be red color. Okay, So remember, myocardial infarct less than 12 hour old are usually not apparent on gross examination. Okay, the first 12 hour, as I said, the gross में कुछ भी नहीं दिखता है. Immersion of tissue slice in a solution of triphenyl tetrazolam chloride is used to identify infarct after 2 to 3 hours of MI. Okay, the stain imparts a brick red color to intact. So when intact will give red color and non-infarcted myocardium, whereas where the dehydrogenase enzyme are preserved. Okay, and infected area reveals unstained pale zone, while old scar infarct appears white and glistening. Okay, because the dehydrogenase is also depleted in the infected area, that you need to know. So this figure, basically the gross picture, it is showing explanted heart of a 20-year-old man. Okay, so what is happening here? Basically here what you can see, here you can see basically you are seeing dilation. Okay, so यहाँ भी ये chamber भी dilate हो रहा है, यहाँ ये chamber भी dilate हो रहा है. So most of the dilations you can see in this. So basically this is a dilated heart. A 20-year-old man undergo orthotopic heart transplantation. With respect to these causes, this cardiac disorder most frequently is. So basically ये क्या है, ये dilated cardiomyopathy की तरफ जा रहा है. Obviously this figure image is showing a dilated cardiomyopathy, and the most common cause of dilated cardiomyopathy is basically idiopathic. Okay, so basically the answer will be idiopathic. Okay, so the most frequent form of cardiomyopathy, so most common cardiomyopathy is dilated cardiomyopathy, and least common cardiomyopathy is restrictive cardiomyopathy. Okay, that you need to remember. Most common cardiomyopathy is dilated cardiomyopathy. Okay, and remember, dilated cardiomyopathy is a very common indication for heart transplantation. So there will be dilation of all four chambers, which will result into thinning of the ventricular walls. There will be systolic, and remember, dilated cardiomyopathy is a systolic dysfunction. Okay, so this is a systolic dysfunction, that also you need to remember. Dilated cardiomyopathy have systolic dysfunction, and there is reduced ejection fraction. Okay, heart acquires a characteristic globular shape. Mural thrombi and endocardial fibrosis are frequent. So there will be mural thrombi and endocardial fibrosis can be seen in dilated cardiomyopathy. Okay, so remember, they are idiopathic, while remaining cases are genetically determined due to alcohol or metal toxicity or peripartum factors. Okay, so other causes are alcohol. So idiopathic is most common causes. Other causes are metal toxicity, alcohol, and peripartum factors. So approximately 50 different mutations can cause dilated cardiomyopathy. Okay, so basically the most important are those genes which involve in coding for sarcomeric, cytoskeleton, nuclear proteins, or protein regulating calcium metabolism. Okay, so microscopic changes, they are non-specific, accentuated, and hypertrophic myocytes and interstitial fibrosis you can see. Okay, and then what you can see, role of endomyocardial biopsy is not for the diagnosis of dilated myocardiopathy, but it is to rule out other conditions which mimic dilated cardiomyopathy, like lymphocytic myocarditis, sarcoidosis, hemochromatosis, anthracycline toxicity, and many others. Okay, so this image again is showing you image. Okay, so what is showing, a 24-year-old man suffers from congestive heart failure. He has no history of therapeutic or illicit drug use, valvular disease, or systemic disorder. A myocardial biopsy shows myofiber arranged as seen in this picture. Occasional fibers contain basophilic granules. These morphological features are most consistent with. So basically amyloidosis नहीं लग रहा है यहाँ. Dilated cardiomyopathy, hypertrophic cardiomyopathy, and infiltrative cardiomyopathy. So here what you can see, basically here the muscle fiber they have undergone, one is basophilic granulation हो रहा है, और another they have undergone basically hypertrophy. Okay, so this will be hypertrophic cardiomyopathy. So this is disarray of myofibrils, myofibril hypertrophy, basophilic degeneration, and interstitial fibrosis is characteristic of hypertrophic cardiomyopathy. Okay, so this is characterized by asymmetric left ventricular hypertrophy, which results in abnormal thickening of interventricular septum. So hypertrophic cardiomyopathy, it is characterized by asymmetric left ventricular hypertrophy, that you need to remember. Okay, then there is basically abnormal thickening of interventricular septum, decreased compliance, and stenosis of outflow of aortic segment. Autosomal dominant mutation of genes coding for sarco. So यहाँ पे क्या होगा, so hypertrophic cardiomyopathy में you can see basically mutation of sarcomeric proteins, with beta myosin heavy chain, okay, heavy chain and myosin binding protein C, okay, beta myosin heavy chain and myosin binding protein C. So now they are associated with metabolic and storage disorders like glycogen storage disorders, carnitine deficiency and Fabry disease, mitochondrial disorders like Friedreich syndrome, and syndromic form like Noonan and Leopard syndrome, okay. So these are the things which with this hypertrophic cardiomyopathy are associated, okay. So another question, 30-year-old woman presents with skin rash and signs and symptoms of congestive heart failure. Investigation reveals impaired diastolic function. So diastolic function है तो basically ये dilated cardiomyopathy तो नहीं है. Hypertrophic cardiomyopathy is basically a diastolic dysfunction, okay. Hypertrophic cardiomyopathy is a diastolic dysfunction, preserves systolic function, and endomyocardial biopsy shows thickened endocardium covered with thrombus as seen in this picture, okay. So there is thickened endomyocardium which is covered with a thrombus. So this is a thrombus, and a mononuclear eosinophilic infiltrate is seen in the endocardium. Which of the following is the most likely diagnosis? So you have eosinophilic infiltrates, you have a diastolic dysfunction, okay. So this is going towards your basically restrictive cardiomyopathy, but here you can see mononuclear eosinophilic infiltrate. So this is characteristics of Loeffler's endocarditis, okay, Loeffler's endocarditis. So there are two forms of restrictive cardiomyopathy, one is idiopathic and another is obliterative cardiomyopathy, okay. So two forms of restrictive cardiomyopathy. So primary idiopathic is sporadic disorder usually affecting children and occasionally associated with myopathy, and secondary obliterative cardiomyopathy which belongs to the group of hypereosinophilic syndrome, okay. So this is called known as Loeffler's endocarditis. So Loeffler's endocarditis, it is a severe disease that involves many organs and tissues including skin, heart and bone marrow. In the heart, it will produce endocardial infiltration by mononuclear cells and numerous eosinophils which are with superimposed thrombi, okay. So this is classical finding you see in Loeffler's endocarditis, okay. So if the patient survives the endocardial damage, heals by fibrosis, and histopathological pictures comes to resemble like endomyocardial fibrosis. So a restrictive heart disease must frequent in South American countries. Then another, there is arrhythmogenic right ventricular cardiomyopathy or dysplasia. So this is not that important at present for you. We'll talk about that. Before this, we need to know that, okay, so you have dilated cardiomyopathy, hypertrophic cardiomyopathy and restrictive cardiomyopathy. Okay, so this dilated cardiomyopathy is systolic dysfunction, other both are diastolic dysfunction, okay, other both are diastolic dysfunction. There will be so diastolic dysfunction, there will be impairment in compliance, but in systolic dysfunction there is impairment of contractibility, okay. So the major cause of dilated is idiopathic, and others are genetics like alcohol, peripartum, myocarditis, hemochromatosis, chronic anemia and anthracyclines, medications, sarcoidosis and idiopathic. So for dilated cardiomyopathy, sarcoidosis is a cause, but pericarditis, sarcoidosis is not a cause, okay, that you need to remember, and this is what they check, okay. So secondary myocardial dysfunction or those which mimic cardiomyopathy is ischemic heart diseases, valvular heart diseases, hypertensive heart diseases and congenital heart diseases. Hypertrophic causes are like they are associated with different syndromes like Friedreich's ataxia, storage disease, infants and diabetic mothers. Restrictive, mostly you get amyloidosis, radiation induced fibrosis and idiopathic. This is also an idiopathic, but restrictive more it is associated with amyloidosis. Now this is again you need to know that different basically involvement of different genes, or you can say so mutation कहाँ hota hai. So see, these are all this in the red, on all this in the red are associated with dilated cardiomyopathy. So basically alpha sacroglycan, dystrophin, desmin, the mutation in these are associated with dilated cardiomyopathy, okay. So basically this titans or mitochondrial proteins all are associated with your what you call it dilated cardiomyopathy, okay. In this all blue color, myosin binding protein C, myosin light chain, okay. So these are associated with your what you call it hypertrophic cardiomyopathy, and all this green beta heavy chain, beta myosin heavy chain, actin, okay. So troponin T, alpha tropomyosins, these all are associated with restrictive cardiomyopathy, okay. Restrictive cardiomyopathy or also both, they are associated with both basically here what we call it dilated cardiomyopathy and hypertrophic cardiomyopathy. So this again, this drawing is in your Robbins. you can understand easily. Okay, so now you need to know here why titin के बारे में कुछ थोड़ा सा, because in exam you will be getting question regarding titin. So titin, mutation in titin, it is the largest non-human protein at approximately 30,000 amino acid. ये एक amino point बन गया, and it also account for 20% of all dilated cardiomyopathy. Okay, so titin is spans, so basically titin, यहाँ पे देखो titin is basically, so this is titin. Okay, titin, and titin is basically your डायलेटेड कार्डियोमायोपैथी, लेकिन रेड में है ना, डायलेटेड कार्डियोमायोपैथी दिखा रहता है, ठीक है. सो नाउ टाइटिन स्पेंस द सार्कोमेर. सो टाइटिन बेसिकली इट इज बिटवीन द जेड and M band, spans the sarcomere and connects the Z and M bands, okay, thereby limiting the passive range of motion of the sarcomere as it is stressed. So titin basically spring like effect होता है titin का, ठीक है, तो flexibility लाता है उसमें. So titin also function like a molecular spring with domains that unfold when the protein is stretched and refold when the tension is removed, thereby affecting the passive elasticity of the striated muscles. Okay, so this basically यहाँ पे बीच में जो मसल होता है ये basically A band dark band हो गया. Okay, and basically this is dark band. Okay, a dark band and the light band. So the light band will have Z and the unit between the two joints, that is known as sarcomere. Okay, sarcomere is the basic unit of the striated muscle. Okay, and so here in between them, here you have all this titin. So here you have titin. So titin protein is spring like protein यहाँ पे बीच में होगा, ठीक है. Now next question, which in order to make a morphological diagnosis of definite myocarditis, which of the following changes is required? So for myocarditis you need inflammatory infiltrate and myocyte necrosis. Very much important, myocyte necrosis होना बहुत ज़रूरी है do you say when you say myocarditis. Okay, so myocarditis is not only inflammation. So inflammation कैसे आता है? Because of necrosis आता है, ठीक है. So definite diagnosis of myocarditis करना है तो there should be inflammatory infiltrate must be present in association with myocyte necrosis. Okay, this you need to know very well. Okay, restrictive cardiomyopathy is not associated with. So restrictive cardiomyopathy, we have talked about restrictive cardiomyopathy किस चीज से associated नहीं होगा. So we have talked about causes of this different myocarditis. So basically important causes of restrictive myocarditis, most important cause is amyloidosis, which I have said. Idiopathic is another cause, radiation is another cause, myocardial fibrosis is another cause. Okay, so others like sarcoidosis is another cause, hemochromatosis can occur, carcinoid syndrome can occur, Fabry's disease can occur, Laffer's syndromes can occur, scleroderma, glycogen deposits, neoplasm. So क्या नहीं आया इसमें? It is alcohol. Okay, so basically restrictive cardiomyopathy is not associated with alcohol, but basically your dilated cardiomyopathy is associated with alcohol. Okay, that you need to know. Mutation in protein associated with restrictive cardiomyopathy. So restrictive cardiomyopathy में कौन सा protein associated होगा? It is troponin I. Okay, troponin I is associated with restrictive cardiomyopathy. Myosin binding protein C, basically they can be associated with dilated cardiomyopathy, or you can say hypertrophic cardiomyopathy. We have talked about them. Okay, see here in this drawing basically is explaining everything. Okay, troponin T basically is associated, can be associated in both, that is dilated cardiomyopathy and hypertrophic cardiomyopathy, but more common it is associated in restrictive myocarditis. Myosin binding protein C, basically this is myosin binding protein C is associated in your hypertrophic cardiomyopathy. Even myosin light chain is associated in hypertrophic cardiomyopathy. In dilated cardiomyopathy it is sarcomeric proteins which are involved. Okay, like alpha sarcoglycan, dystrophin, desmin, so they are associated with dilated cardiomyopathy. Okay, so here again, so troponin I, okay, mutation in troponin I3 gene and myosin heavy chain 7 gene are the major cause of the condition. Okay, so myosin heavy 7 gene beta myosin heavy chain बोलते हैं. Troponin I3 gene is cardiac troponin 1 and 3, troponin 2 cardiac troponin T type 2, and ACTC gene actin gene. Okay, so question, mutation in which of the following cause hypertrophic cardiomyopathy? So hypertrophic cardiomyopathy, myosin binding protein C. Okay, myosin binding protein C. So basically myosin binding protein C is associated with hypertrophic cardiomyopathy. Myosin binding protein C. So myosin binding protein C is associated with cardiac. But remember, troponin T and all can also be associated. Cardiac troponin T, troponin I can also be associated, but most commonly is myosin binding C is associated with dilated cardiomyopathy. Okay, so with this much we end our cardiac region. Okay, we end our cardiac cases. Okay, and so it has been already more than 1 hour. So we'll continue this our general compilation. So today we just compile heart part. So most of the part of heart we have covered. Okay, so we covered about rhabdomyoma, we covered about myxoma. Okay, we covered about tumors. That is, most important tumors are secondary tumors, and most important one are myxoma and rhabdomyoma. So if you get questions in heart, you are going to get a question regarding rhabdomyoma or myxoma. Then we covered about cardiomyopathies. So cardiomyopathies will, most of the question in cardiomyopathies will be regarding causes. Okay, causes of cardiomyopathy, and also regarding your mutations. That are the most important causes and most important mutations which you can see in cardiomyopathy. So that will be okay. Ischemic heart diseases, you need to completely read from your medicine. Okay, we'll try to come mostly in pathology question regarding ischemic heart disease very less. You will be getting that in your medicine only, and so I didn't collect any question regarding ischemic heart disease, but this more or less covers your heart. Okay, this more or less covers your heart. So basically now you can once go and read your Robbins, basically your heart can be completed. Okay, thank you very much, and see you in next class. We'll try to do general pathology compiled one also, and one system. So today because I have become really late, it was on, so we'll take another class of general pathology and compiled pathology MCQs. Okay, thank you very much.